everyone, welcome to the session of clinical enzymology. So now we will start with the clinical enzyme profile in various organs. We'll start with the cardiac biomarkers. A biomarker is a clinical biomarker which is rising when there is an injury to the heart. So that includes enzymes as well as other compounds. So that's why I am not saying clinical enzyme profile of heart. I just said cardiac biomarkers, which it include biomarker which is not an enzyme also. So the enzyme or the cardiac biomarkers are the creatine kinase MB that we have already discussed in the creatine kinase isoenzyme. Then TROP-T and TROP-I, which are called as the cardiac troponins. Then LDH and AST. These are the enzyme profiles that was used in the as a marker of cardiac injury. But LDH and AST is no longer clinically used. CKMB and the cardiac troponins are the one which are used very commonly nowadays. So when we see these cardiac biomarkers, what we have to know is what is the time that it is starting to rise, when it is peaking and when it is coming down. So based on that, we can have an idea about what is the time duration and also what is the disorder. We can diagnose the disorder as well as we can diagnose the time of onset of the disease also. So first we'll see the creatine kinase. The creatine kinase MB start to rise about 4 to 8 hours, then peak is at one day, almost 24 hours it is peaking, and then it goes to normal by about 2 to 3 days, 48 to 72 hours. Now about the cardiac troponins. The cardiac troponins, there are two types of troponins, T and I. It's almost, both are having almost the same time of onset, that is around 4 to 6 hours. Peak at about 24 hours, just the same as that of CKMB. And the advantage here is it is lasting longer for about 7 to 10 days. Then TROP-I also start to rise 4 to 6 hours, then peak 24 hours, and to 7 to 10 days it will last. So T and I is almost the same. Then LDH and AST start to rise only after one day, then it peaks in 3 to 6 days and it lasts longer for 2 weeks. Then AST, it starts to rise about 12 hours, then it peaks at the second day. Then it stays for about 4 to 5 days. But these two are clinically not used now. So if we draw a diagram of the rise and the time of onset of various cardiac markers, what we can see is first what I am drawing is the creatine kinase MB, which start to rise about 4 to 8 hours. So this is the point, 4 to 8 hours. Then it peaks at 24 hours. Then it is there for about 48 to 72 hours. So that is the graph that we are getting for CKMB. Now for cardiac troponins, we know that it is starting to rise 4 to 6 hours. So that is what I am drawing here, 4 to 6 hours. Then it peaks. Then it comes down and it stays there for about 7 to 10 days. So it is staying for a longer duration like this. So this is cardiac troponin. So that is the difference in the graphical representation of onset, peaking, and how long they are there in the blood. So that is the different time that we are seeing these cardiac biomarkers, and among this we have to learn a few more points. That is, when you compare CKMB and cardiac troponins, which is more specific, cardiac troponins is more specific than CKMB. So even if I have told you about all these cardiac biomarkers, which is the first biomarker to rise? The first biomarker to rise is myoglobin. about 2 hours itself it starts to rise, but it is very non-specific. It is not at all specific to the heart, so we cannot consider this as a cardiac biomarker only. So that is the one disadvantage of myoglobin, but it is the first marker to rise. Then CKMB and cardiac troponins almost rise at about 4 hours, so there is not much difference in that. Then why I am saying that cardiac troponin is more superior than cardiac CKMB, it's because one, it's more specific. Then one more advantage is there for cardiac troponins, that is this cardiac troponins, now there are high sensitivity monoclonal antibody based assays are there, which can detect cardiac troponins to less than 1 nanogram per liter. So even if the presence is very less, that is less than nanogram per liter also it can detect. So that is the importance of knowing the high sensitivity monoclonal antibody based assay for cardiac troponins. So initially I've told you AST and LDH is now clinically not used. But still there is a question that is asked regarding the LDH, that is called as a flipped LDH pattern. What is this flipped LDH pattern? In normal person, what we have seen is LDH2 is more than LDH1. That is, the RBC form is more than heart form. But in myocardial infarction, what happens is it is reversed. That is, LDH1 is more than LDH2. So this is called as flipped LDH pattern. Then one thing more to discuss in the cardiac biomarker is brain natriuretic peptide. Brain natriuretic peptide or BNP is not a marker of ischemia. It's a marker of volume overload. And circulatory failure. So if there is a heart failure, then the brain natriuretic peptide is a much better marker, not cardiac troponins. So that is the difference in brain natriuretic peptide. So with that, we finished the importance of cardiac biomarkers. So now we'll start the enzyme profile in liver disease. Enzyme profile that is used in the liver disease is divided into two. Markers of hepatic injury and markers of cholestasis. Markers of hepatic injury are transaminases. The transaminases are ALT and AST, alanine aminotransferase and aspartate aminotransferase. Markers of cholestasis are gamma glutamyl transpeptidase. The second is 5' nucleotidase. And the third one, alkaline phosphatase. So first we will cover the markers of hepatic injury. So markers of hepatic, to understand the markers of hepatic injury, I'll show you a graph to explain the transaminases elevated in various injuries to the liver. I'll just explain it with this table. No need to learn these numbers. This is just to explain how the different distribution of ALT and AST differ in various organs. So first I have highlighted there is a ALT that is elevated around 2850. You can see in all other, if you see the distribution of ALT together, the maximum elevation of this transaminase, that is ALT, is seen in which organ injury? It is in the liver. So that is why we say the ALT is more specific for liver injury than AST. Why? What's the problem with AST? See, in the case of AST, you can see all the numbers. If you can see the highest elevation, you can see in several places. So the organs that you can see in the heart, in the liver, in the skeletal muscle. So in all these organs, if there is injury, AST level will rise. But ALT level, if you see, it's specific for liver. So that is why we say ALT is more specific for liver disease. Total, if you are seeing the overall activity of these transaminases, what we can see is the activity of AST is more than ALT. That is there, but still, if you consider liver, the ALT is more specific. But AST is non-specific, as it is elevated in the heart, liver diseases, skeletal muscle, then kidney and pancreas. So that is why we say ALT is more specific, and then we should understand its location. Then we should know its intracellular location. Where is it located? ALT is exclusively intracytoplasmic. Okay, so it is intracytoplasmic. What about AST? AST is located in cytoplasm and mitochondria. Okay, so if there is a mild injury and all, ALT level will rise. AST level will rise if there is mild injury, and also especially if the mitochondrial injury is also, then the AST level will be more. So that is very important, that ALT, AST, where is it present is important. So now we will learn a very important topic, that is AST-ALT ratio. Remember, AST is in the numerator, ALT is in the denominator. So that's why we call it as AAR, that is AST-ALT ratio. Now, if you take the AST-ALT ratio, it can be less than 1 or more than 1. So if it is less than 1, then the probable causes for that is chronic viral hepatitis, then non-alcoholic fatty liver disease, then toxic hepatitis, and acetaminophen toxicity. Why? Because in all these cases, the ALT elevation is more than AST. So that is why there is, and also you can see all these are liver disorders, and it is all affecting the liver. ALT is a more specific marker for liver diseases than AST, and in all these cases, ALT level is more than AST. That is why the AST-ALT ratio is less than 1. So in all these cases, then what will you see in these disorders like alcoholic hepatitis, hepatic cirrhosis, liver neoplasia? In all these cases, the AST-ALT ratio is more than 1. The AST-ALT ratio is more than 1. So why? In alcoholic hepatitis, what happens is, in alcoholic hepatitis, we can see there is an injury to the mitochondria. There is injury to mitochondria. We know the location of AST is mitochondrial. So as the alcoholic disorder is affecting the mitochondria, what we can see is the AST level is also rising, and it is above ALT level. So that is why the AST-ALT ratio is more than 1. In hepatic cirrhosis, the story is different. In hepatic cirrhosis, the reason is a different one. That is, AST is cleared from plasma by sinusoidal cells of liver. Okay, so in hepatic cirrhosis and in liver neoplasia, this clearance of AST from the hepatic through the hepatic sinusoidal cells is affected. So what will happen? The AST level will rise more than ALT. So there also what we can get is the AST ALT ratio is more than 1. So it is very, very important to understand and learn that what is the AST ALT ratio. What are the disorders causing less than 1? Less than 1 is usually hepatitis, acetaminophen, toxicity, etc. Whereas if it is going for alcoholic, then or in the case of hepatic cirrhosis and also in neoplasia, the clearance of AST is affected. So AST ALT ratio is more than 1. So that is about the AST ALT ratio. Now this is a graph to explain the transaminases or the aminotransferases level in various disorders of the liver. So you can see this is the amount or the activity, total activity of the aminotransferases, and here what you can see is the ischemic or the toxic injury to the liver. Then there will be maximum elevation. So there will be maximum elevation if there is a toxic elevation or toxicity to the liver. Then acute disorders like acute viral hepatitis, the elevation is more. Then gradually the autoimmune is coming, the elevation level is coming down. Then alcoholic liver disease, it is very less. Not very less, it is less than the other acute injury to the liver and all. Then if it goes to the chronic hepatitis, liver cirrhosis, etc., we can see that the amount of transaminases that is increasing, the total amount is less. So in short, what we can say is if it's an acute disorder, or like an acute injury to the liver, acute inflammation, then there is marked elevation. Whereas if it's a chronic disorders like chronic hepatitis, liver cirrhosis, then the level of elevation is less. So that is what we can learn. Another question I want to ask is a scenario. The scenario is like this. A young adult went for a liver function test. So when he analyzed, or when the report was analyzed, all the liver enzymes were within normal limits, but there is a mild elevation of ALT alone. So mild elevation of ALT. Then what is the probable cause? Most probable causes of fatty liver. So all liver enzymes within normal limits, no other symptoms are there, but only mild elevation of ALT. Most probable causes, that is a fatty liver. Okay, so that is about the different markers of liver diseases that is affecting the hepatocytes. Now we'll go to the other end. Markers of cholestasis. The markers of cholestasis are the alkaline phosphatase, then 5' nucleotidase, and gamma glutamyl transpeptidase. So we'll see one by one. The alkaline phosphatase. Already we have seen about alkaline phosphatase. It's a non-specific marker. It's elevated in so many conditions. Particularly in the case of liver disease, it's a marker of cholestasis, and the isoform which is present in the epithelial cells of. So this alkaline phosphatase is present in the epithelial cells of biliary canaliculi, where in the membrane, it is present in the cell membrane. So it is present in the cell membrane, and the isoform which is present in the biliary canaliculi was the alpha-1 alkaline phosphatase. And this alpha-1 alkaline phosphatase, so generally we say alkaline phosphatase, I told you that is marked elevation of alkaline phosphatase is seen in obstruction. So cholestasis, marked elevation is seen. So if there is a marked elevation of alkaline phosphatase, there are two types of cholestasis. It can be within the liver or outside the liver. So this is a marker of extrahepatic obstruction, like the stones in the common bile duct, or a cancer of the head of pancreas obstructing the common bile duct, etc. So if we see the next one, And also I have told you it is a non-specific marker. Non-specific. But alkaline phosphatase, we can get marked elevation in cholestasis. Okay, so about 5' nucleotidase. It is a specific marker of cholestasis. So if a question on cholestasis, all the clinical features of cholestasis is asked, both ALP and 5' nucleotidase is there, then what should be your answer? It should be 5' nucleotidase. So it's a very specific marker, and it is also present in the cell membrane of the biliary canalicular cells. But it is not present in other sites, so that is why it's a specific marker. Then we'll go to gamma glutamyl transpeptidase. Gamma glutamyl transpeptidase is located in the cell membrane and in smooth endoplasmic reticulum, otherwise called microsomes of the hepatobiliary system. So when you compare this gamma glutamyl transpeptidase with the 5' nucleotidase and alkaline phosphatase, then the GGT is less specific for cholestasis. And it is more or less elevated in intrahepatic and extrahepatic obstruction. Extrahepatic cholestasis. So it is a marker of cholestasis, but when you compare it with the alkaline phosphatase and 5' nucleotidase, it's given as less specific. Then what is the importance of gamma glutamyl transpeptidase? It is a marker of alcoholic hepatitis, then heavy drinkers, then drugs like phenytoin and phenobarbital. So in all these disorders, what happens is, especially in alcoholic hepatitis and heavy drinkers, what happens is there is involvement of microsomes. So as microsomes are involved, the gamma glutamyl transpeptidase level is increasing, especially in alcoholism, and that is heavy drinkers, alcoholic hepatitis, etc. Gamma glutamyl transpeptidase is more useful.